Hi, my name is Sharon Benoit. I want to apologize for being late. Unfortunately, my calendar said Susan was picking me up, and Susan called me up and said, "Hey, are you here?" I said, "No, I thought we're meeting in 5 minutes." She's like, "No." So I apologize for that, and I appreciate all of you showing up here. I'm part of the Division of Surgical Oncology, so what that is we do mainly cancer surgery, but we also do other things in addition to it. So basically, a thoracic surgeon operates on everything in the chest except for the heart. So just to give you a brief factoid. But we're going to talk about lung cancer, and let's see here. Is it this thing? Yeah. Lung cancer is the fifth cause of cancer mortality. I'm sorry, it's the fifth. Lung cancer is the fifth cause of mortality, period, but out of cancers, it's the second most common lung cancer in terms of new cases. It's the #1 cause of cancer deaths amongst men and women, okay? And so if you look at, breast is the most common in women and prostate is the most common in men. If you add up colon cancer, breast cancer, and pancreatic cancer deaths per year, lung cancer still exceeds that rate, which is pretty significant. It's second leading cause of all deaths following heart disease, okay? And heart disease has a wide myriad of things. And the one factoid that someone told me was that the number of people who die from lung cancer per day is about 433. The number of people on a 747 is 416. So this is the same as a 747 crashing every day, and yet it gets widely ignored. So how many of you know when Lung Cancer Awareness Month is? What about Breast Cancer Awareness Month? October. Lung Cancer Awareness Month is November. So, but unfortunately the blame tends to go toward the patients in a subconscious way. Oh, they smoked, they deserved it. But that's not the case, and we're going to go into causes of that. If you look here in terms of spending that the NIH spends, okay, so over about $1.3 billion is spent by the NIH for heart disease. For lung cancer, $233 million, okay? Breast gets $800 million a year, colon cancer, $300 million a year, prostate cancer, $257 million a year. So the second leading cause of death in the country doesn't get much compared to the other types of cancers. If you look at how much they spend per death, okay, HIV/AIDS, each person they spend about $425,000, $997 per death. For lung cancer, it's $1,400 per patient who dies per year. Stage. So lung cancer tends to present at a more advanced stage at about 56%, okay? And so 15% of all lung cancers are localized. That means stage 1 or stage 2A disease, okay? 56 is metastatic disease. 22% have regional disease. What does that mean? That means that it has spread to the lymph nodes. Lymph nodes are the cleanup crew of your body. So for example, when you get a cold, you have swollen glands. Those are your lymph nodes fighting the infection. Lung cancer likes to spread to lymph nodes. In looking at trends in 5-year survival rate, pancreatic cancer has the worst 5-year survival rate at about 7% for both African Americans and Caucasians. Lung cancer, second, 18% in Caucasians, 15% in African Americans, and then liver, 13, 17%. So lung cancer, you can see, has a very poor 5-year survival rate compared to everything else. If we look at our state, okay, so South Carolina, Caucasians are in red, okay, and African Americans are in green in terms of mortality rate. Well, it's actually pretty on spot compared to, the U.S. in terms of the trends. However, we do have a higher mortality rate for both Caucasians and African Americans compared to the national survival rate. The incidence in the United States is about 80 and 55.1 per 100,000 for men and women. In our state, 94.1, 53.9 per 100,000. Let's see here. Okay. terms of age-adjusted rates, okay, so you can see that we've got a lot of reds up here in terms of how we do as you get further in the periphery of the state. The mortality actually gets better. Incidence rates, still pretty high. This is the tobacco belt, unfortunately. Causes. So 90% of lung cancer is caused by active smoking, okay? However, about 15% occupational carcinogen exposure, okay? So I know a lot of people have worked in the mills down here. People have been exposed to asbestos. Asbestos, I know that we all see commercials. If you have mesothelioma, you can sue. Actually, asbestos and tobacco smoke combined increase your risk of lung cancer by about 400%. Radon. So my husband and I are actually buying a house, and we found out that the house we're looking at is high radon levels. And so that's about 10% chance, and you have outdoor air pollution, about 1 to 2%. So although tobacco is a leading cause of it in terms of active smoking, there are still other causes. And so people who now develop lung cancer, 20.9% are current smokers. 43% are former smokers. 17.9% are non-smokers, and this number is rising, okay? So if you look at it, about 61% of people who have lung cancer are non-smokers right now. So there are two types of lung cancer, and we're not very smart in terms of thoracic surgeons, so we have small cell and we have non-small cell. Small cell comprises about 15% of all lung cancer. It is associated with smoking, but symptoms can be coughing up blood, weight loss, bone pain, debility. And so the workup includes a chest x-ray, sometimes you get labs, a CAT scan, a PET scan, which is a scan from the eyeballs to the knees that gives a sugar dye. So cells that are active, cells that are revved up, take up that sugar dye. Can be cancer, but it can also be inflammation. It can also be infection. So a PET scan doesn't tell you whether or not you have cancer. MRI of the brain, so small cell lung cancer does like to go to the brain. Bronchoscopy biopsy, that's how we get tissue. So whenever I have someone who has a CAT scan that looks suspicious for cancer, I don't tell them they have cancer until I have tissue proving it. Because I've taken things out of people that I thought was a cancer, it was an infection. So that's just my bias with it. Even when it's screaming, I'm cancer, I don't like to tell people that. In terms of staging, there are two stages. There's limited stage and there's extensive stage. So limited stage just means that it's isolated to the tumor itself. It hasn't spread to the lymph nodes. It hasn't spread anywhere else in the body. Extensive stage can be any tumor size, any nodes involved, anything all over the body. Most of these patients present with the extensive stage. About 2 to 5% have limited stage, and these are the patients who are surgical candidates. Everyone else, they require definitive chemoradiation therapy. And so treatment is chemotherapy and radiation. These patients will get prophylactic brain radiation regardless of what stage they're in, and that's because of the propensity for it to spread to the brain. The response rates can be 60 to 90%. However, the survival rates still are not that great. For limited stage, the survival rate's 40% at 2 years. For extensive stage, it's less than 5% at 2 years. Non-small cell comprises about 85% of lung cancers. And there are different types. There's adenocarcinoma, that occurs in the glands in the lung. Squamous cell carcinoma, that occurs in the lining of the airways. Large cell, neuroendocrine carcinoma, which are carcinoid or large cell neuroendocrine, these can sometimes secrete hormones. We talked about risk factors beforehand, but smoking, radon gas, secondhand smoke, 5%, asbestos. You can also have environmental exposures or occupational exposures such as chromium, arsenic, nickel, cadmium, silica. These patients can present with coughing, hemoptysis or coughing up blood. They can have weight loss, shortness of breath, they can have pain. Sometimes it's an incidental finding. So let's say you're getting your gallbladder taken out and they get an x-ray beforehand. They find a spot in your lung, and that's what happens. Or you come into the emergency room, you get a CAT scan to rule out a kidney stone, and they find a spot. And so that's how it can present, and so that's where we get to see those early stage cancers. The workup similar to small cell in terms of a chest x-ray, labs, the CAT scan, PET scan, MRI. You could do a bronchoscopy to get tissue, and EBUS. What that is that's an ultrasound. And what that does is it's actually a way to biopsy the lymph nodes, and we'll go into that a little bit later. Pulmonary function tests or breathing studies. So if someone's an early stage lung cancer, you can operate on them, but we get breathing studies beforehand. And then we like to get a biopsy. So the preoperative assessment. So when we meet a patient, we do a history and physical. We do what we call the eyeball test, okay? So how active are you? Okay, you come in, you're walking in, you're like, hey doc, I feel good. That's different than someone who comes in on a stretcher who can barely talk or walk, okay? In terms of, also we ask, what does the referring physician say? So let's say one of you people comes to see me, your referring physician or your primary care doctor has developed a relationship with you over years. They know you better than I do, and they might say, yeah, I think that, you know, Ms. Smith is going to be a great surgical candidate. Or they might say, you know, Ms. Smith, she may not be the best person to undergo surgery. And so we kind of rely on the referring provider's judgment. Objective stuff we look at. So the imaging studies. So the CAT scan, the PET CT that we talked about, the breathing studies, cardiac clearance. So this can be stressful on the heart. So we want to make sure, can the patient's heart tolerate it? The last thing we'd want to do is to put, I'm sorry, I'm from the north, so I don't know how to bless people's heart very well, but we don't want to kill anyone in the process of curing them. And I don't think anyone would want that as well. So CAT scans. What does it do? It looks at an obstructing lesion, looks at vessel involvement, looks at lymph node size. So it's CAT scan, what it does is it takes pictures of you, slicing you like a bread loaf, this way. And so on this CAT scan, this is the patient's front, this is the back, this is the right side, here's the left side. This is the spine right here. This is the artery going to the lung. And this thing right here is their lung cancer, okay? And it's very, very close to the blood vessel supplying the left lung. PET scan. So this is the scan we talked about with the sugar dye, okay? And so what that does is it looks not just at the tumor, but everywhere else in the body, from your eyeballs to your knees. So we look at the lymph nodes. We see, do they light up on the PET scan? What size are they? It looks elsewhere. So has this spread to the liver? Has it spread anywhere else, in order to help us understand what's going on? So this is a 52-year-old male who was sent to me who had a 2-centimeter mass right here in this right upper lobe. And you can see how bright yellow that is. And so that is that's a very active lesion on the PET scan. Well, over here is a lymph node, okay? That is also very active. And so what do we do on this patient? We biopsied the lymph node, and that showed cancer, and that this had spread to the lymph node. So in that case, the patient would receive chemotherapy and radiation therapy, followed by surgery. Then we also want to see, are they able to breathe okay? So one thing I like to ask patients is, how far can you walk? Okay? Can you walk up a flight of stairs? And then they'll say, oh yeah, sure. And they say, okay. And then I start upping them. What about 2? What about 3? So if you can walk up 3 flights of stairs, you're at low risk for a lobectomy, or removing the lobe that is involved with the cancer. If you can walk 5 flights of stairs, you're at low risk for undergoing a pneumonectomy, or taking out the entire lung on that side. If you cannot walk up a flight of stairs, you're at increased risk of a perioperative death after resection. So the other thing we also look at is, are you going to be able to participate in your care after surgery? Because it's a big surgery, and so can you cough? Can you walk? Can you deep breathe? If you can do those things, then great, then we can go ahead with the surgery. But if you can't, then you're at an increased risk of pneumonia, and that can lead to other problems to the person. And so here we are operating on someone and compromising their lung already by taking some away. And if they get pneumonia, that compromises more lung. There are different types of resections. So what a lobectomy is we take out the lobe. The right lung has 3 lobes, an upper, a middle, and a lower lobe. Left lung has 2 parts, an upper and a lower lobe. So this shows a picture of what a right upper lobectomy looks like. A pneumonectomy, taking out the entire lung. Wedge resection, that's wedging out a piece of lung like a piece of pie. I call it a haircut. Segmentectomy, so what that is taking a segment of the lung. So what that is it's based on the blood vessels that go to that section of lung. Okay, so we've got arteries, we've got veins, and we've got a bronchus or airway or supply or a pipe that supplies air to that portion of the lung. And so what are our tenets of resection? Well, we want to remove the tumor with a clear margin. We don't want to leave anything behind. If you're going to do an anatomic resection, which is a lobectomy, a segmentectomy, a pneumonectomy, we want to take the artery, the vein, and the bronchus. That's what we're there for. And we also want to biopsy all the lymph nodes because that is important in staging the person. So there are different ways to approach the patient. So one way is what's called a posterior lateral thoracotomy. What that is an incision that starts between the shoulder blade and the spine, kind of curves around and kind of goes to your side. Okay? This is considered one of the most painful incisions in surgery. And we divide a lot of muscles. We divide the latissimus muscle, intercostal muscles, your trapezius, your serratus, your rhomboid. And so this is a painful incision, but it's a safe incision. Okay? And so people did it for many, many years before they started going into minimally invasive surgery. And so what some people do is thoracoscopy. What that is surgery through little incisions, and you can actually take the arteries, the veins, and the bronchus and do a lobectomy that way. So have any of you guys ever had your gallbladder taken out? Go ahead and raise your hand. How many had them through the little incisions? Okay. Pretty quick recovery time, huh? So this is the same thing, but in the chest, okay? You had one of those? You had a bad lobectomy or gallbladder?
No, right here.
Okay.
The lung collapsed.
Oh, okay. So that's what a thoracoscopy is. Another thing that we do now at Greenville Memorial Hospital is use the robot. So this is what the robot looks like, okay? It is not like a microwave. We don't push a button and walk away and say, robot, take lung out for us, okay? And no, it has not become, contained, it has not become self-aware, so it's not going to become the Terminator and kill all of us or anything like that. But what it is that it allows us to work in this little console here, so we're in the room, and all the movements that we do with our hands, the robot does. So it allows us to do really precise dissection and allows us to do more complex resections than we could with thoracoscopy. The incisions for the robot, you can see, this is one patient. This is the biggest incision right there, and that's about 1.5 inches in size. And that was to take the lung out, okay? And so people have a very fast recovery from it, okay? But we can't forget, and I always tell patients, you're having major surgery through minor incisions. So it doesn't negate the fact that they didn't have a big surgery. They did. It's just they had it through little incisions, so it means a faster recovery time, but we still have to be hyper vigilant about the bad things that can happen. Survival rates for lung cancer. So 5-year survival rate for stage 1A, that's the earliest stage lung cancer for non-small cell, can be 73%, okay? As the stage goes up, the survival goes down, okay? So stage 4 can be 13% 5-year survival rate. And that's because there are different types of stage 4s that we can sometimes operate on them. Now, how do we keep the survival rate from being so low? How can we shift everything up to the stage 1A? Well, that's with lung cancer screening, okay? And so we talked about more than 75% of lung cancers are diagnosed in advanced stages, okay? So now, in terms of screening status, when you have this stage shift in terms of people who have lung cancer screening, okay? So what is lung cancer screening? It's a CAT scan, okay? And what that does is you get an annual CAT scan based on certain criteria, and this way you can discover lung cancer earlier. So now you can see that more people are being diagnosed earlier with the screening. So people say, well, what about a chest x-ray? Unfortunately, a chest x-ray is not as good as a CAT scan because a chest x-ray only is a 2-dimensional view. So it's kind of comparing, let's say, a black and white photograph to a high definition movie. You're going to see a lot more with your high definition movie. So why do we need this? Why do we need lung cancer screening? We talked about it. Breast cancer, prostate cancer, colon cancer, pancreatic cancer combined. Lung cancer mortality is higher than all of those. One thing we look at is the timeline, okay? So this is one patient who has a baseline screening, nothing seen on the CAT scan. Great, okay? So come back in a year for another CAT scan. Come back in a year, you've got this little spot here, okay? So it's about 16 millimeters in size, okay? So about 3/4 of an inch. So what do they recommend? Well, follow up closely. Let's see, does it change in size? Sometimes you can have spots in the lung. For the sake of them being spots in the lung, they get smaller, they get bigger. Well, this one got bigger, okay? And this was actually a small cell lung cancer, okay? So what is the screening eligibility for lung cancer screening? Well, you have to be age 55 to 77 years old, asymptomatic, so no signs or symptoms of lung cancer. You have to have a greater than 30 pack year smoking history. That means number of packs per day times the number of years that you've been smoking. And you have to be a current smoker or one who has quit within the last 15 years. You need to have an order from your physician, and we look at all these things, you know, smoking status, etc., provider number. And the thing that's important whenever you have a lung cancer screening program is, well, what do you do with the information? I gave a talk a couple years ago and it was called Lung Cancer Screening, Now What? So we do the screening. Well, first of all, how do we ensure that the patients get the close follow-up that they need? I'm sure the ladies here know when you get your mammogram, you know, you get your little card in the mail, okay, time for your mammogram and those kinds of things. So it's making sure that you have the infrastructure necessary to follow up these patients, because some of them, you get a repeat CAT scan in 3 months. Some of them, okay, we'll get another CAT scan in a year. And so it depends. And so what we have at Greenville Memorial Hospital is we actually have a meeting every Monday where the surgeons, the radiologists, and the pulmonologists go over the CAT scans of people who have spots in their lungs. And we say, all right, do we all agree? Follow up in 3 months. Do we all agree? Follow up in a year. And so this way, everyone who might be involved in the patient's care is involved. So it's a multidisciplinary conference. So lung cancer is the leading cause of mortality in both genders. The presentation can be ubiquitous. You can be completely asymptomatic, okay? Or you could just have some fatigue, or one patient of mine had hip pain. CT screening can reduce the mortality associated with lung cancer by detecting earlier stages. So if we have the stage shift, that means we're able to treat it earlier, which means a greater than 5-year survival. And that's all I have for you. Thank you.